So it's perhaps a bit unusual that as the one heading this Academy Series, I'm also a speaker, but since nobody else offered a kind of political perspective on primary healthcare, I felt really I need to step in for the first time also as a speaker to talk about the geopolitical dimensions of primary healthcare, because it was really a major development and event in the whole history of global health, an event that has really its impact until today. First of all, I will fulfill the task that is given to all the speakers to explain what global health research means for me personally, and for me certainly the comprehensive nature and the interdisciplinarity of global health research is the most unique selling point of it. It's more than in other fields I have ever worked before, and it's important when if health issues transcend borders, and that will be even more the point today in my lecture. It's important when the solutions require a global collaboration and cannot be only national solutions. In this series, we also want to talk about research methods and materials. That's what I will be starting with. And then I have 5 points. I will show that there are many origins, many sources of the primary healthcare policy identifiable. I will show why it nevertheless took some time until this policy became really an internationally, at least officially internationally accepted one. And after this highlight of the conference of Alma-Ata, that then the reception of this new generally accepted policy was really quite different in different parts of the world, and also for different parts of the world. And perhaps some conclusions, some lessons learned can be taken from this. What I tell you is based on really more than 20 years of research in different projects at different occasions. Main funding came from Volkswagen Foundation in a project on East Africa, and from DFG funding on West and East Germany, a comparison. So I have the perspective of what happened with the policies on the spot in an African country, and what happened in some of the so-called donor countries. Global health research, like any global history, requires a lot of traveling, at least so far, with increasing digitalization that might decrease in the future. But for this research, really, I had to visit archives in Tanzania at 3 places, in the archives of the former colonial powers, in this case Britain and Germany, and also, of course, in Geneva with WHO. You cannot only rely on what is in the archives, the written sources, but if you still find eyewitnesses, then oral history done in Germany and Tanzania is an important part of this work. Usually, global health history is not something which is suitable for medical students' doctoral projects. But if you have such a larger research surrounding environment, then you can really invite also medical students to participate, because they get some inspiration, they get some correction and so on in this research group. And so we were also able to have some student projects on leprosy work, on medical missionaries in India, on the changes in German international aid in healthcare, and on microbiological collaboration integrated into this research over the decades. And we had also some international conferences held where we invited others to present their perspectives and compare them with what we found out in our projects. I would like to start with some ideas on what would constitute actually a primary healthcare approach, even avant la lettre. That means even before this policy was finally decided on in Alma-Ata. And I would say primary healthcare is there where these challenges that you can be listed here are somehow met. Yeah, so it's about the extension of healthcare to so far neglected communities, especially rural communities, which means that you need to have biomedical workers there, which will be mostly non-doctors. You need to decide which are the health issues to tackle. So those that are most common and those where you can really do something about because they are amenable or avertible. But for this, you definitely have to adapt the kind of interventions. That means the medicines, the technologies, the ways of health education. You have to identify especially vulnerable groups and have special and develop special programs for them. You have to collect the information on the most burning health issues and also their actual development, of course. And you have to see how you can increase health literacy in the population on prevention and cure, because otherwise the population would not know when to seek help or how to protect themselves. So what were the historical sources of such an approach, meeting these challenges that I just listed? The first in many parts of the world were actually, before the colonial conquest, often the medical missions, because these medical missionaries had some treatment to offer for the most common diseases. They founded dispensaries for it, enlarged them later into hospitals with also some basic surgery. They needed the assistance of local health workers for many tasks and established training programs for them. And they started also health education in the health facilities and in their schools. But that was not fully blown up primary healthcare, because what they lacked was really an administrative authorization for public health. So they rarely did vaccinations and they could not order anything for disease control. So then another actor needed to come in for this, and these were the colonial medical administrations. They were very much confined initially in their tasks. They were only focusing the colonial staff at the beginning with their hospitals and control campaigns of the most important communicable diseases. After the First World War, they extended their services by permanent dispensaries, but only for prioritized diseases. So for a long time, it was not something where you could go with any complaint and find aid, but it was rather part of this major attempt of disease control. And then for disease control also, as you can see here, local health workers had to be trained and included. That's one source. The other is actually socialist medicine, because two major socialist countries, the Soviet Union and then the People's Republic of China, wanted to extend healthcare services to populations that had been completely neglected by the previous regimes, by the imperial regimes of the Tsar and the emperor in China. And here, especially in China, the model of the barefoot doctor, of somebody with only a very short training in the most common disease, and especially also in prevention, that had been established during the so-called Long March. That means the conquest of China by these red troops. This model was then extended as the backbone of rural healthcare in Mao's China. And I have to mention a fourth source, and that's the Health Organization of the League of Nations, because they demanded from those territories, those colonial territories that were mandates of the League of Nations, that they would develop the territory and introduce welfare activities. And so in late colonialism, for example, this very important report by a leading medical sociologist of that time, Richard Titmuss, was commissioned by the still colonial government and then delivered to the new independent government of Tanganyika. As you can see, AMREF, our partner in this primary healthcare research series, was already editing this report. So they have really quite a long track record in primary healthcare. And the major change in this report, the proposed government policies, was really away from medicine and sanitation only to comprehensive health services, which also included renaming, and a new kind of institution, somehow positioned between the dispensary and the hospital, was the health center for integrated health services. So here we have already somehow most elements of primary health care contained, but perhaps not all, as we will see. Why did it not develop after the Second World War, after the founding of WHO, as many had hoped for, comprehensive basic healthcare services all over the world? One of the reasons is certainly are the geopolitical tensions at that time, the Cold War, because as you can imagine, I talked about the Soviet system, completely government controlled, and the US system was, of course, one of private, rather market-based healthcare. And that there was no common denominator in health system policies. And so the only thing early WHO could work on, because there was agreement, was eradication campaigns. It was not different, actually, from much of development aid that was starting at that time, international financing of projects, because it was partner-oriented. But who were the partners? Mainly presidents, or in the NGO sector, bishops. And what they wanted to have was really a tertiary care hospital at the place where they lived, for their family, for their groups. And the healthcare for the remote rural population was not really of much concerns for them. So partner orientation is not sufficient if you have the wrong partner in a way. And then there was also quite a lot of resistance from the medical profession, because they found that delegating tasks that had been the prerogative of medical doctors to non-doctors was not acceptable, and also putting too much effort on prevention would take away resources that are needed for cure. So here there was really quite a sometimes marked resistance from this quarter. There were also advocates of PHC at this time. There was the movement of the medicine of poverty that said most of the diseases are not tropical diseases, but are diseases caused by poverty and have to be treated under the conditions of poverty. Then there were many community-based pioneering healthcare projects, especially in Asia and Latin America, some of them by medical missionaries. And this led actually to a process of reflection and to the founding of the Christian Medical Commission of the World Council of Churches in Geneva, close to WHO. And here, US public health experts like Carl Taylor, for example, played a major role. So this kind of basic healthcare was no longer just a socialist interest and activity, but was taken up also in some Western countries. And the then long-time Secretary General of WHO, Halfdan Mahler, a Danish doctor, specialist on tuberculosis, took up these ideas, was heavily influenced, because perhaps also his father had been a missionary. And so these ideas of community-oriented healthcare at the lowest level gained momentum. There was a resolution of the World Health Assembly in 1977, and also UNICEF, the United Nations Fund for Children, could be got on board, and this led then in the end to this unexpected, we must say, really event of the Alma Ata conference, where the majority of countries in the world sent delegates, and also many NGOs. The Soviet Republic of Kazakhstan offered to host it. Of course, then the interest was also to prove to the world the achievements of this socialist healthcare approach that I mentioned. It was a conference which did not only consist of the usual plenary sessions, working groups, and so on, but also had well-organized field trips to basic healthcare institutions in the region. The declaration that came out of this conference is, of course, in the tradition of WHO. So the definition of health by the WHO has taken up also the idea of health as a fundamental human right. But due to these geopolitical tensions that I mentioned, the aspect of the right was not really very much emphasized. Please also note it's health for all, not for everyone. So the individual aspect perhaps not as was not as emphasized as we would do it later on. The WHO Director General also avoided the term human right because we have this different understanding of it between the West and the East. And so it was no real point of discussion. But this was not so problematic because besides being a fundamental human right, health is also, as the WHO repeatedly declared, a social goal. So everybody could find somehow a justification for engaging in primary healthcare. I think the 8 elements of primary healthcare are well known to you. So the more important ones are the primary prevention outside the health sector. Then we have some of them that concern preventive services in the health sector. And in the end, the rather curative part of medicine, of treatment, is taken up. But the new thing in primary healthcare at Alma Ata were not these elements, because all of them can be already found in the colonial or missionary healthcare, for example. But the new thing was really the principles. So there was a strong emphasis on equity now. It should be for all. And different from the top-down approaches of the colonial time and early independence, it should be community-based, so the community should have a chance to participate in the design, in the development, in the evaluation of healthcare activities. And new is also the emphasis on intersectoral coordination, collaboration. So the sectors of education, of water, of agriculture should all be contacted and integrated into the activities for improving health. Then some advocated especially appropriate technology. So the highly sophisticated technology used in industrialized countries would not fit to many situations and should therefore be adapted. And another idea was also that those experts on health that are already there, with of course quite a different kind of idea of health and disease, the traditional practitioners, traditional healers, should be gained as collaborators in the attempt to establish primary healthcare, especially for the messages on disease prevention. On the photograph here, you see one of these field visits during the conference where a tent of nomads is visited by health workers in Kazakhstan. Yeah, so I think the policy itself, the event is well known, but what we have to see really is that the reception afterwards was quite divided. So the Eastern Bloc, especially the Soviet Union and their allies, they did not engage very much in the health systems of other countries because they saw their role already fulfilled as in serving as a role model. Yeah, all the countries should become like the socialist countries of the North were already. So they were not thinking of adaptation, and the idea of central planning, which is the opposite of community participation, of course, was really quite important for this approach. So for many reasons, also political reasons, they did not engage with a lot of staff and other offers in the so-called young nations. That means those countries that had gained their independence in the past decades. In the West, that was completely different, the reception, because they were really dividing the world into two different healthcare models. So what was decided in Alma Ata was regarded by most Western countries and governments as a policy for the developing countries, for the global South. Yeah, they need this kind of approach. We in the industrialized countries have a well-established doctor-centered approach that could be continued. So different health policies for the global South and the global North. But in their development aid, development cooperation, the Western donor countries required the fulfillment of PHC in the lower middle income countries as a condition for getting the assistance, getting the money. Yeah? So in this way, they enforced it as a policy for the global south. Yeah, and then we had another group of important actors, the international agencies. And here some of them broke away from the WHO approach by proposing selective primary health care. That was first, especially the World Bank at the Bellagio conference, and then also UNICEF joined it, because there was the feeling we have already some highly efficient tools, also cost-efficient tools, and we must need these tools like vaccination, like oral rehydration salt, like the growth charts for the monitoring of children. And we cannot wait until the whole health system has developed according to the policies of Alma Ata. And this selective primary healthcare was called the Child Survival Revolution. So this was a very short overview, of course, over these different steps of precursors of the conference itself, and then of the divided reception. So I think what we can learn from it actually is certainly that primary healthcare means a very long process. It needs a change of the mindset. It needs quite a lot of advocacy work with governments and other actors. So it's not really about quick fixes like effective vaccines or medicines or other interventions, but it's really about a change in the approach to health. And then it's also dependent on many external factors in space and time. So the first could be called path dependency. Reforms like primary healthcare must build on the existing healthcare system. You cannot erase everything that has been before. You must really look for the existing healthcare system, and then you can build on this with new policies, introducing new interventions, new incentives, and all this. And the second, regarding time, the window of opportunity. So for many decades, such a joint global proposal of a healthcare policy was impossible because of the geopolitical tensions. And only in these few years, in the 1970s, we had this, what was called the small detente, before with neoliberalization and the era of Reagan in the US and so on, we had a new kind of Cold War afterwards. So you must really make use of a window of opportunity that may open. Well, what we have also seen is there is a strong ambiguity even of central terms. So the East and the West, the North and the South understand different things by healthcare systems. But it might be good at some points to accept this, to tolerate this ambiguity for enabling collaboration, the formulation at least of a joint policy. There might be later conflicts because of the different understanding, but to keep the world together, perhaps it's sometimes also good to accept this ambiguity. Yeah, and I think the most important lesson in the end is there is really no alternative to primary healthcare. So even in the global north that said at the beginning, well, primary healthcare, that's nothing for us, that's for the global south, we have to accept now that we will not able to continue our healthcare system if we do not strengthen primary healthcare. Because if everybody goes to a medical specialist or even the hospital directly, every health system in the world would be overburdened in the long time. So the first levels of healthcare must be strengthened in all parts of the world. Yeah, and because this is really seen by many experts and also government officials. The World Health Report in 2008 rightly emphasized that primary healthcare now more than ever. It's not an outdated policy for a certain period of development cooperation, although it had its high time perhaps in this period, but it's really an approach that we need to consider and strengthen in all parts of the world and in most areas of global health. Yeah, so here are the published results that we, what came out of our research projects. Few of them also in German, because we also especially wanted to address a German audience to educate it a bit more on these issues. And then, of course, there are also there's a lot of research literature, especially by those historians like Marcos Cueto or Socrates Litzios himself, a malariologist before, that work in collaboration with WHO and also have contributed to the history of the World Health Organization. Yeah, thanks for your attention, and I'm really looking forward to your questions and our discussion after the breakout session.